We're going to get going. Thank you, everybody, for coming. For those of you who I don't know, I'm Sandro Galea. I have the privilege of serving as the Dean of the School of Public Health. It's my great pleasure today to introduce an old colleague and friend, Dr. Tom Farley. Let me just tell you very briefly about Dr. Farley, and I'm sort of trying to figure out whether to start more recently or distantly. Let me start distantly. So Dr. Farley has a medical and public health degree from Tulane University, and he spent a good part of his early career in Louisiana. He served as the Louisiana medical officer of the Louisiana Office of Public Health. He was also on faculty at Tulane, where he chaired the Community Health Sciences Department. While in Louisiana, he worked extensively on many things that affected the health of New Orleans while he was there, including after Hurricane Katrina, working on rebuilding the city's public health infrastructure, meaning that he lived through a really exciting and interesting time. His career in public health then took a turn for the also more interesting, or equally interesting, when he moved to New York City. And he eventually became the health commissioner of New York City, which he served with enormous distinction for about 4 years. The New York City Department of Health and Mental Hygiene has about 6,000 employees, about a budget of $1.5 billion. And Dr. Farley was the advocate and the lead implementer of some public health policies that really have now become trend-setting and groundbreaking throughout the country, including making cities, parks, and beaches smoke-free, raising legal age of tobacco to 21, something which is currently being discussed here in Massachusetts, and also pushing forward on the effort to cap the portion of sugary drinks sold in restaurants at 16 ounces, which I know has been discussed quite a bit in the school. When Dr. Farley was commissioner of New York Department of Health and Mental Hygiene, I had the enormous privilege and pleasure of serving on the health board, which was chaired by Dr. Farley. And in the process of serving alongside Dr. Farley, I really got an opportunity to see him operate. And I came away with the experience with deep admiration for someone who truly is a consummate public health professional who has devoted his career to improving the health of the public. Dr. Farley has recently written this book called, in the sort of dramatic name, Saving Gotham, A Billionaire Mayor, Activist Doctors, and the Fight for 8 Million Lives. It is a terrific read, actually. I was just complimenting Tom that I thought what was most amazing about it is that it's just like a really good read. It's sort of like, it reads like a thriller. It's like a car chase. It's really cool. But more seriously, it is, as far as I'm concerned, the most readable book, the most readable narrative about how a city health commissioner goes about doing his job and improving the health of the public. For those with a sort of slightly more academic bent, Dr. Farley also wrote in 2005 with Deborah Cohen the book Prescription for a Healthy Nation. That book, as far as I'm concerned, remains the best book for a lay audience about social determinants of health. I admire both books very much, and I also deeply admire the work Dr. Farley has done. It's really a pleasure to have you with us. Tom.
Thanks very much, Sandro. It's really a pleasure to be up here in Boston. This talk, I imagine you know, but if you don't, this talk is one in a series of talks that Dean Galea established called Turning the Tide. And I'm not sure if you saw it, but he sent out to the speakers a list of questions to frame the series. And when I looked at those questions, I thought, first of all, these are important questions. These are the questions that we need to answer if we want to change the trajectory of health in this country to be where I think we ought to be. I also thought that these are very difficult questions to answer. They're difficult questions to answer. No one else has the answer to them. That, in a way, makes this talk kind of fun for me because I can speculate. Since no one knows the answer to these questions and I can say what I want, I can sort of shoot my mouth off. I'm somebody who tends to be more evidence-based and adheres closely to the data, but today I'm going to have an opportunity to go off a little beyond that. So I'm going to organize my talk mainly around those questions, which I've boiled down a little bit. But first I want to start with a little bit of background on why we should be addressing those questions in the first place. And I'm going to use this here. This is actually a slide that I stole from Sandra, by the way, which came from originally an Institute of Medicine report, which I think gives you one picture of what's right and what's wrong with health in America today. This is life expectancy among males, and as you, in the US in the red dots compared to other high-income countries in the gray dots. And as you can see, our health data in 2007 or so is just about last. If I were to show you this graph for women, I think we are last. And I sort of knew that, but I didn't realize until I saw this graph that it wasn't always the case. That if you look back in 1980, we were around the middle of the pack. So it shows that while our health is improving in this country, we are being surpassed by other high-income countries of the world. And the only thing that you can conclude from looking at this is that there are an awful lot of Americans who are dying prematurely, unnecessarily. That these other countries that have economies not as strong as ours, that spend less money for health than ours, are far healthier than we are. So we need to change that. And how are we going to change that? Well, these are the three questions which I boiled down out of the, 6 or 7 that was on the list. And I put them in the order which is going to make it easier for me to answer. And that is, how do we define the priorities for contemporary public health to try to change that trajectory? And why are population health approaches squeezed out by individual solutions? And then how can we communicate convincingly the quality of life return on investment on populations? So let me take the first one first. And I'm going to actually go this question one step better. I'm not just only going to tell you how we can define the priorities for contemporary public health. I'm going to define the priorities for contemporary public health, at least from my opinion. And if you want to define priorities, I think you need to start with what the health problems are. This is the leading causes of death in the United States, and I don't think they'll surprise anyone in this room. If you look on down the list is dominated by chronic diseases like heart disease and cancer and diabetes. There are some injuries at the bottom, right? Suicide and motor vehicle crashes and poisonings. So we live in the era of chronic diseases and injuries. And that may seem like the natural order of things, but if I were to show you this graph 150 years ago, it would have been entirely different. It would have been dominated by infectious diseases. And I suppose if I were to look at this graph 150 years from now, it may be very different too. So this is, though, the challenges of our era. And how do we solve these health problems? Well, in public health, we don't act on diseases for the most part. We act on the determinants of diseases. So how do we think about the things that determine chronic diseases and injuries? And this is, there's different schemes out there, but this is a scheme that's put forward by Tom Frieden, current director of the CDC. That's what I'm calling the Frieden Pyramid. And he's got at the bottom socioeconomic factors, and it being broader, representing what he sees as the largest impact. And then he's got changing the context, what I would think of as your day-to-day environment. Then he's got 2 levels there that I think of as clinical interventions. One he calls long-lasting, and the other he calls clinical interventions. Then he's got counseling and education. Now, I want to actually simplify this fairly simple graph further and put it into 3 levels. One that I'm going to call healthcare access and quality, and one that I'll call behavioral and environmental risks. Behavioral environmental risks, that would be like smoking and like air pollution. And one I'll call social determinants, like poverty and like racial segregation. And to determine priorities, we have to start by thinking, how many deaths do we have that we can attribute to each of these three categories of problems? I want to try to pull in some data to try to answer that question, to give a sense for priority here. How many deaths are we losing in this country due to inadequate healthcare access and quality, for starters? Well, there are some estimates that have been put out there for how many deaths are attributable to lack of health insurance. And that's sort of a good proxy for that. And you can see it's in the order of tens of thousands, less than 50,000. Not insubstantial, but not huge either compared to some that we're going to see. But that's healthcare access. What about healthcare quality? We know that healthcare quality in this country is far from optimal. And this is a sort of complicated graph from a study that I did a few years ago with Tom Frieden, where we just did a little thought experiment and said, well, what would happen if everyone in the United States got clinical preventive services that are proven to be effective as often as they should? And so what this graph is showing is on the x-axis is the percent of people receiving a proven clinical preventive service, and on the y-axis is the number of deaths prevented. And so if you look at, say, hypertension treatment, the one that's got the solid line there, it says that right now about 40% of people with hypertension are adequately treated. And if we brought that up to 90%, then we might be able to save 70,000 to 80,000 lives per year. Now, there's a lot of room for error in this, and to give you a ballpark sense. And there's also probably double counting for these different interventions that would prevent cardiovascular disease. But if you put this all together, you can figure out, well, maybe 100,000 deaths could be prevented from improving healthcare quality. So more probably than through healthcare access. What about behavioral and environmental risks? You know, some years ago, probably 1990s, there was a paper that got widely quoted by McGinnis and Fahey, where they talked about what they call the actual causes of death. Many of you have probably seen it. It was a very simplified view that said that there are more deaths attributable to smoking and unhealthy diet and physical inactivity than many other problems. We now have a more sophisticated version of that now. This was done by a group at the University of Washington that did the Global Burden of Disease study, where they looked at proven risk factors and tried to come up with a number of attributable deaths for each. And as you can see there, surprisingly to some, the number one cause for them was unhealthy diet in all the different ways it could be unhealthy. Then they got smoking. Then they have two more after that that are to me, kind of biologic markers of risks. They're not the sort of thing we tend to act on directly in public health. Then you got physical inactivity, and a couple more that relate to physical inactivity and diet. And then you got air pollution and alcohol and drugs. So this is the ranking of things that we could prevent, we could change, and if we did, we could save a lot of lives. But now look at the number of deaths we got at the bottom here. You can see it's almost an order of magnitude greater than the ones for clinical services. So they're estimating almost 700,000 deaths potentially preventable through changing healthy diet, and 480,000 for smoking. Now there's definitely double counting here as well, but it does give you a sense of the order of magnitude for this. Well, is there anything like this for social determinants? In fact, there is, done by your dean in a paper that I think deserves more attention. I think conceptually it was really a brilliant paper. This is to try to do the same thing, the McGinnis and Fahey paper, but use it for social determinants like low social support and poverty and racial segregation. And you get a sense for the order of magnitude here as well, that 150,000, 250,000. So a large number of deaths, like the others, is probably double counting across the different bars. But you get a sense that it's probably bigger than clinical services, but maybe not as big as behavioral and environmental risks. So this is just trying to assemble those all together on one slide, and please don't anybody hold me to these numbers. You can assemble them as well as I can, but I try to give you some sense of the relative size of these. Healthcare access and quality would be the smallest, behavioral environmental risks in the middle. I mean, it would be the largest, and the social determinants would be then the lowest. All right, well then, if that's a sense of what the priority problems are, then what about how we're going to solve those? I'm going to put clinical services off the table now because to me it's too small compared to these other issues, and just talk about the other two. What about behavioral and environmental risks? Well, these are the big five that came out of that graph that I showed you earlier. What can we do about those five? Well, for starters, we have to recognize that those unhealthy behaviors don't happen in a vacuum. They happen in a context. This is the context that I think of when I think of poor health in America today. It happens to be a store in New Orleans where I spend an awful lot of time. And remember what the biggest health problems were, that there was smoking, and that's there, and there was unhealthy diet, and that's there, and then there was alcohol consumption, and that's there. So they're selling the leading causes of death, all right? And you may think that they're just meeting demand, but don't forget that they're also advertising the leading causes of death, okay? There's an awful lot of push to do that. And so our response to this ought to be to create an environment where, a context where people are being less promoted to, where healthy choices are easier. And that way of thinking about these problems has come under this phrase that I hope you all know by now, which is called policy and environmental change. This is what public health people have gravitated to in the last 15 years or so about how to address at least these behavioral risks, and I want to say the environmental risks as well. So I'm going to run down very quickly now and give you a policy agenda for those five health problems within this category, policy and environmental change. And I won't describe them in detail because there are other things I want to get onto. But for smoking, we want to have things like restrictions on marketing. We want to have smoke-free air laws. We want to have tobacco taxes. Those we know all work, and they work quite well. We can apply the same approach to improving our food environment with things like restrictions on specific ingredients that we know are particularly bad for health, like sodium and trans fat, with policy changes in government food programs like SNAP, and with healthy food policies in schools and workplaces and communities. For physical activity, I think everybody's gravitated to the idea that we need to create a built environment that's more supportive of physical activity and less supportive of sedentary behavior. So that means a transportation infrastructure and land use that facilitates active transportation, more parks and recreational spaces. Air pollution, that's the easiest, right? We ought to be regulating emissions. And for alcohol, well, we ought to be following the same model that we follow for tobacco, with things like restrictions on marketing and taxes. So there's a policy agenda that we all should be working on, and each of these, one could probably take the rest of our careers. But it's a pretty good policy agenda that ought to save an awful lot of lives. Then that raised the question, what about that third level? What about those social determinants? Can we come up with a similar policy agenda for them? Well, I haven't been working in those for as long as I've been working in this area, but I've got to believe that we can do that. And so I would start with these problems as being sort of the parallel to these behavior problems I showed you a minute ago. These are sort of the category of social determinants that are out there in the literature. Some of these are more amenable to clear public policy action than others. These ones in bold are the ones that I say are more clearly something we can affect through public policy. And I'm not an expert in these, but I do want to just throw out some ideas for policies that might address those. These are not policies that that are new to people, but these are policies that you don't ordinarily hear public health people talking about. So for income inequality, you think about, well, minimum wage increases. That's going to reduce income inequality, a more progressive income tax, raising the earned income tax credit, and stronger unions. Unions have been organizations that have really maintained wages for a long time in this country, and they're much weaker now than they used to be. For racial and socioeconomic segregation, there are clearly policies that can be put in place at the local level with zoning and tax incentives for mixed income development. For education, you could think of as a starter, more public funding for higher education. Employment, you can think about government jobs programs. You can think about investment infrastructure. So I don't mean to imply in any way that this is a comprehensive list or that this is even the most important policies on the list. The point of showing this is that there are a list of policies that we can put in place that address these social determinants, and public health people generally don't talk about them, but we should talk about them as health-promoting policies, not just as social policies. And the potential out there is pretty substantial in terms of number of deaths prevented if we can make a difference in these. Now, we won't probably be the determining voice in that conversation, but we should certainly add our voice to the chorus talking about these issues. So that's my public health priority agenda. I went through in about 10 minutes, but it's certainly a couple of lifetimes worth of work. Now I want to get to more difficult problems, difficult questions. So the question, why are solutions like that, that aren't that hard really to come up with, why is it that they're squeezed out by individual solutions? My answer to this question is that we don't control the media narrative in this country. There is a media narrative in this country. We live in, and in the world these days, we live in the modern media age. We watch television, we look at our cell phones, we're on the computer all the time. It's almost rare that we're actually speaking to people face to face. And there is a commonality to the way that we communicate things through that media. And the public health mindset doesn't come out through that narrative. The individual approach does. I would say we've lost the narrative if it weren't for the fact that we never had it, okay? This is something that's been dominated by the individual approaches for a long time. And just to give you a sense for what I mean by this, if you were to turn on the news and get a story on health, you're going to see a story like this. Medical marvels, right? Modern medicine is going to be able to do everything. It's going to be able to cure cancer. It's going to be able to cure your heart disease. It's even going to be able to reverse aging. Okay, you see this all the time and on a very steady level. So that's if you were to watch the news. If you were to watch entertainment, you're going to get something pretty similar. I think the show is launching today. It's a heroic doctor out there with his team, and he's going to be able to solve whatever health problems you have. So it's in news, it's in entertainment, it's also in advertising. Hospitals can do everything, therefore we do everything. And so pretty constant there as well. It goes throughout that. Now, all of this is talking about cure. It's not talking about prevention so far. Actually, there is a media narrative around prevention in this country, and the narrative is you can do prevention all by yourself. It's all about you. Okay, you have the power to live healthy. And for that matter, if you don't do it, it's your own fault, because everything is in your power. If you just go out in your backyard, you have this beautiful green space where you can jog, and there's 2,400 other people doing it, so what's the matter with you? So, just do it. Just quit complaining. It's your own fault if you don't do it. So that's just sort of the sense of things. I wanted to bring in a little bit of evidence in here. Some years ago, an organization called the Frameworks Institute was given a grant to try to understand the narrative around obesity. And so they pulled 95 news stories, and they coded them according to whom do they attribute responsibility for the obesity problem. And you see overwhelmingly it's individual adults. Some battering of other people there, but to the extent that they raised the possibility of any responsibility from the food companies, those claims were refuted in the same story. Okay, so very dominant theme that the problem is individual adults. Prevention is an individual adult responsibility. So that should raise the question of why that's the case. Why have we chosen in this country to have this individualist frame? If you were to ask someone in the media that question, excuse me, they're going to answer that stories of individuals are just naturally more compelling. Now, you put a human face on someone who's suffering or who's getting better, that's more compelling than numbers. And that is true. But it is also incomplete because it is also true that the individualist frame sells products, right? It sells medical care. It shows health insurance, those things we're spending an awful lot for, so that now it persuades us we are in fact getting our value out of that. It also sells other products that promise health, like the gadgets and nutritional supplements, et cetera. It also conveniently absolves those corporations that are selling those unhealthy products and government of their responsibility. So those organizations that are putting out the products that really have an impact on our health that I feel are at least in part responsible for their health, if it's an individual's frame, they don't exist whatsoever. Remember that the media is almost entirely in this country paid for by advertising, right? And there's an old saying that if you're getting something for free, the thing that's being sold is you. And that's what's going on. The advertisers are really shaping that narrative. And so who are the advertisers in this country right now? This is the leading advertising industries. And think about what our leading killers were. Tobacco's not on this list because they can advertise, but they promote in other ways. But you got the food industry here, you got the beverage industry and alcohol there. Think about physical inactivity. You got the automotive industry there and media there. That's what we do when we're sedentary. We're either driving or we're consuming media. And for that matter, you've got pharma medicine there. So the industries that are really shaping that conversation are the industries that have some responsibility for our health or are benefiting from when we have poor health. So that absolves the industry. And then the final reason is that it avoids conflict. Those of us in public health tend to come in for all the right reasons. We're big-hearted, caring, warm people. We want to get along with everybody. We want to embrace everybody. We don't like conflict. We tend to avoid conflict. If we talk about a food industry or even a tobacco industry as a source of a problem, then we're entering into a conflict. We're getting into battles that we don't tend to like. And so this individualist frame is much more comfortable for people to be in than a frame that really thinks about the context for health. So that's the problem. Now it gets more difficult. How can we actually solve that? And the question that Sandra asked was, how can we communicate convincingly the quality of life return on investment? I want to rephrase that a little bit. Say, how can we change the narrative? Because I think it's really not going to be by putting more numbers in a journal, it's going to change that. I think it's going to be really engaging with the media in trying to change the narrative. And it's worth pointing out, though, that as kind of depressing as that last section was, we've had some real successes in public health over the years that we can draw some lessons from about what we can do in the future. This is an area where we've had real success over the years. This is, you've probably seen this, this is cigarette consumption as a proxy for smoking rates throughout the 1900s. And you can see it rose and it peaked in the 1960s and it's been falling. There are, at the inflection points, you can get a sense for what's causing some of those inflections. So big social changes like the Great Depression, there's a big run up here in the 1940s during World War II when soldiers were given free cigarettes. There's a media effect here. The first smoking and cancer concern in the 1950s caused an immediate drop-off in cigarette consumption. Overall, now, and these years here, we are winning. But during this period here from 1900 to 1960s, we were absolutely losing the media narrative, and the tobacco companies were dominating this. Hollywood had pictures like this all the time, and stories on television as well. This isn't just happenstance. It's totally out there in the open that the tobacco companies were paying for these scenes to happen, to have it be very attractive actors smoking, and that gave this very positive image. When I was a young kid in elementary school in the 1960s, advertising of cigarettes on television was common. I saw ads like this all the time. I can still sing the cool jingle. Anybody else my age probably can as well. And the way that they sell cigarettes is obviously not through an educational approach. It's through an emotional approach that associates the smoking with our aspirations. That we want to be attractive like those actors there, therefore we're going to smoke cools. It makes no sense logically, but it works. And but this happened in the 1960s, but public health entered the fray in the late 1960s during a period when something called the Fairness Doctrine was applied to cigarette advertising. What this was said that the federal government said to media outlets, television stations and radio stations, that for every 3 cigarette ads that you show, you need to show 1 counter ad for cigarettes, and you need to provide that time for free. So American Cancer Society and other health organizations were able to get free media time for ads like this. If you go back and look at these ads today, they look incredibly unsophisticated. And you can't imagine that they would have had any effect whatsoever. But look what happened. Right here, you see this little notch there. This is the period when the Fairness Doctrine was applied. Cigarette sales started to plummet in this country. They plummeted so fast that the tobacco industry got terrified, and they voluntarily went to Congress and they said, please ban our ads from television and radio, if only we make sure that you get rid of those counter ads as well. And Congress did pass that. The tobacco industry then rechanneled their advertising dollars into outdoor and print, and smoking rates rose again. So it was a very instructive lesson there that even when we were outspent at least 3 to 1, we could win in public health by engaging in the conversation, and even if our ads really weren't all that sophisticated. So now we think of media messaging as only having an effect on consumers, but media messaging can also change the policy environment as well. So what's the message with this ad here? If the message is, well, secondhand smoke kills, so maybe you shouldn't smoke around somebody else, or you shouldn't be around someone else who's smoking. But there's also a message here to somebody who's, say, an employer, says maybe you shouldn't allow smoking in your workplace. And for that matter, to a legislature, maybe we should have a smoke-free air law. And that was precisely why these sorts of campaigns were run in the 1990s, was to try to pave the way for smoke-free air laws. And they worked. Smoke-free air laws had not covered the entire United States, but they're much of the United States right now. So it just points out that a consumer-directed message can do more than just have an impact on consumers themselves. Now, I want to show you another way that public health has engaged in the media narrative. And this, I love this example. I'm going to go out on a limb and say that this one ad changed the history of tobacco control in this country. Before and after, things were different. And I'll explain what I mean after I show it. So let me make sure I do this right.
Every day, 2,000 Americans stop smoking, and another 1,100 also quit. Actually, technically, they die. That means that this business needs 3,000 fresh new volunteers every day. So, forget about it. Cancer, heart disease, emphysema, stroke stuff. Gentlemen, we're not in this business for our health.
So before that ad, tobacco companies were just legitimate businesses. They were meeting a consumer demand. No, didn't have any moral, positive or negative view to them. After the ad, we knew what tobacco companies were. They were a bunch of evil white men sitting around trying to figure out how to addict people to a product that they knew was going to kill them. suddenly the tobacco companies became evil. And if a tobacco company became evil, that meant that that was a company that an elected official didn't really want to be associated with. And so it paved the way for an awful lot of policy approaches getting sympathetic view from elected officials than was the case previously. And this view that the tobacco companies and tobacco executives are evil, it lives on today. So Tom Frieden was my predecessor as the New York City Health Commissioner. When he came in, he announced his priority was going to be tobacco. And he said, tobacco company executives are mass murderers. And he wasn't hesitant to do that. And to me, I can trace a lineage of that phrasing to this ad, and I think it's been a very useful tool over the years. Which then, that leads me to sort of back up a little bit and talk about how I think media messages and policy initiatives work jointly to create social change. As the diagram, I'm thinking about how individual behavior occurs and the way the influence is on it. So individual behavior happens with influences from organizations and influences from government, but also the influences work the other way as well. So to the extent that individuals behave in a certain way, say that they smoke or they drink sugary drinks or they exercise, that influences the policies of organizations and policies of government, and their policies influence them. And if you try to change any one of the three corners of this triangle and don't change the other two, you get pushback. So if you were to try to persuade people to not smoke at a time that there wasn't any organizational policy change and everyone was still smoking at the workplace, you would have difficulty. If you were to try to get a smoke-free air rule in place while everybody was smoking and supportive of the idea, you would have difficulty. And likewise, if you try to change a smoke-free air rule. So what you want to do is somehow influence all three corners of the triangle at more or less the same time. And that's what media messages do, that they have an impact on individuals. They also have an impact on organizations because people who work in organizations are themselves people. They watch the same television shows and read the same newspapers that we do. And likewise, the people in government are people like anybody else, and they are subjected to the same media exposures that the rest of us are. And they communicate with each other through the media, so that if you have some involvement in the media, you change the way they interact with each other. And if those messages are all saying the same thing in different forms, whether it's news, whether it's entertainment, whether it's videos, documentaries, or tweets, then everyone gets a sense that the world has changed and the social norm has changed. That's what's happened, I think, with tobacco from the 1960s on to now, this relationship between media messaging and policy proposals that shift the policies of organizations. And that's what has happened, I think, in the last 15 years around sugary drinks. And I want to show you how that has happened in New York City and to a certain extent nationally by tracking this one indicator. And this is the number of newspaper articles in New York newspapers that simply mention the words obesity and soda in the same article. Right? So in the 1990s, we had almost no mentions whatsoever of obesity and soda being connected. Then in the early 2000s, there was some talk that, because of the obesity epidemic, maybe we shouldn't be selling soda in schools. So there was discussion of school vending bans, and so we got more articles about that. Then that was more or less dealt with, and those articles tailed off a bit. Then in 2009, in New York City, we started running counter-advertising around sugary drinks in the same way that we did counter-advertising around tobacco. This was our first ad. It was on the subways in New York. We did it based upon focus groups when people showed us that they couldn't really imagine a liquid like soda turning into a solid like fat when it got into your body. You knew hot dogs might make you fat, or French fries, but not soda. So we showed them a bottle of soda turning into fat when it gets out of the bottle. And we also made it kind of disgusting at the same time so that they would have that association. When we did this, the advertising agency on their own decided they wanted to have a little fun with this and do a video as well. So they did this sort of on their own. So we ran that ad. Actually, we didn't have money to place it on television, so we just put it on YouTube and sent out a press release. In about 2 weeks, we had about 500,000 views. So it was popular. People were sending it as, this is the most disgusting thing I've ever seen. You got to look at it. We also, at that time, put forth a series of policy proposals around sugary drinks. We proposed to put a tax on sugary drinks at 1 cent per ounce. That died in the New York State Legislature. We proposed to prohibit sugary drinks from being on the list of allowable items in the food stamp program. That was turned down by the USDA. And then we, as you probably heard, we did propose a 16-ounce cap on the size of portions of sugary drinks sold in restaurants, and that was killed in the courts. So all of those failed from a strictly policy perspective. But what happened? Each of those drove a tremendous amount of news stories, particularly the portion cap. And so in each of those news stories reinforced the idea that sugary drinks caused you to get fat, that they were bad for your health. And then I can't entirely take credit for this, but look what happened in 2014. In Berkeley, they passed a soda tax by referendum by more than 70%. And so the entire social norm had changed. Not only did people now know, which they didn't know at the beginning, that sugary drinks are bad for you, but they knew it so much and they thought it was so important that they were willing to tax themselves to address that problem. Now, there were many other things happening around the rest of the country, but clearly the narrative around soda has changed, and it has changed because of this interplay between our policy proposals and our counter-advertising. Now, it changed so much that actually something like this started to happen. This is an ad that we did not have anything to do with, but we discovered it, and it showed that the company was taking advantage of this new world.
Americans drink over 13 billion gallons of sugary beverages every year. Overconsumption may lead to obesity, heart disease, and diabetes. It's an epidemic, but we can help change it with a simple everyday choice. Drink more Brita water. Clean, clear, refreshing Brita water. Nothing is better.
So the point is that even that company recognized that the world had changed so much around this issue that they could take advantage of it, and that they reinforced our message. And then what happened? Well, this is surveys tracking sugary drink consumption in New York City in adults in the blue line and youth in the pink line. The measure here is the percent who drink 1 or more per day. And there were big declines during this entire period. So even though we didn't get any of our policies through and you could buy just as much as you could before, people are turning away from these sugary drinks. So that's just an example of how media messages and policy proposals can work jointly to change a narrative, and then ultimately it changes an individual's behavior. Now, I should say I still think those policies are good. We still want them in place, but even without them, we're able to have a big public health impact. Which then that brings me, that was all about behavioral and environmental risks. What about, can media messages help address social determinants? That's a fair question to ask, one I've been asking myself a lot lately. If these are the issues we want to deal with, can we change the way that the media talks about these issues in ways that makes progress on those issues from our perspective? I honestly don't know the answer to that question, but I can only know this much about it, and that is, if you think about the major social movements that have happened in this country in the last few decades, all of them involved a fairly sophisticated use of media. The civil rights movement, the environmental movement, gay rights, gay marriage movement, these have been very sophisticated in the use of media. They haven't necessarily had paid campaigns, but they certainly have used that. And so I've got to believe there's a role for media and these social determinants as well, as yet to be defined. So let me just sum up then, that I think transforming health in America is really going to depend on requiring social change in these two areas, behavioral and environmental risks and social determinants. And let me just go on a tangent for a second there. I'm surprised as I talk to people around the country, how many people jump immediately to these social determinants like poverty and racial segregation and kind of skip over the behavioral and environmental risks for which we have good evidence that we can save a lot of lives. I think we ought to be doing both, and I think we can be doing both, and I wish more organizations would focus on that middle layer there. I think public health should be clearer than we have been to date in articulating the policy solutions that we think are going to save the most lives in this country. I don't think that's hard to do. I just think we need to be more clear and more specific about it. And then I think we should try to create that social change by engaging in two things, policy advocacy and then media messages like this. So that's my idea, my attempt to answer these difficult questions. I'm happy to hear what your all's perspective is. Thank you very much. Got a question there?
What do you think of the new discussion around repetitive brain trauma in children and football and long-term consequences?
I'm not an expert in it, but I'm certainly, as a pediatrician, scared to death by this information, and it does make you question whether we should be playing football at all. I don't know the answer to that, if there's a way to do it more safely. I think it's going to take a while for our country to come around to that conclusion, because football is so much religion in this country. But as has been pointed out, at one time, the biggest sport in this country was boxing, and that is viewed now to be too brutal. So I don't know much about it, but I do worry about it. Yeah?
Tom, that was terrific. Can you, tomorrow we're doing that was really terrific, thank you. Tomorrow we're doing a Dean's seminar on firearms. Can you comment on issues that seem as intractable as firearms, where they do seem to be religion in this country, but where we know we can save 25,000 lives tomorrow with a policy change?
Yeah, I do view firearms as a public health problem. It's not recognized enough that it's a problem beyond just homicides. It's also suicides, as a bigger problem than homicides. And so it's the mechanical object itself is a risk. And I absolutely think that as public health, we should try to engage in that public discussion beyond just going to academic conferences, and try to be getting messaging like this out there. It would take some thought as to exactly what messages would be appropriate right now to move the national conversation the way we want it to move, but I think we could probably do that, and I would love the opportunity to do that. Yes, I got you, and then I have you in the back later.
Hi, thanks so much for your talk. I'm curious if communication in mass media is a part of the solution, and changing the narrative is part of the solution you proposed. If you would also recommend that marketing and training be a part of core public health, or core
Yes.
public health training. I think I always laugh at some of the public health posters I've seen put out. They're good faith efforts, but we are not near to the level of savvy as many of our media peers. So I just was wondering if you could speak on that.
I absolutely do think that we are pretty good at conveying information. We're terrible at communicating in this modern world of images, and we ought to learn more about how it works so that we can be smarter consumers of it and recognize what's being done by industry, and also so that we can engage in that same conversation. This is the modern vernacular, is video. Yes?
Thank you. You showed some very interesting decreases in the consumption of soda in New York. Have you been able to look at changes in rates or prevalence of obesity in the population of New York?
Yeah, we have seen declines in obesity in children of like 6th grade and lower in public school, stabilization in kids a little bit older, but unfortunately we're still seeing rises in adults. It looks like the rate of rise is not as much as it was before, but I don't know whether we can claim credit for that. Even when we got into this with sugary drinks, we recognized that they were not the entire obesity epidemic. I've been saying it maybe a third to a half of the obesity epidemic could be ascribed to that one item. Even if it's a third, if it's a half, anyway, you wouldn't expect to see an immediate change. You wouldn't expect to see an immediate reversal. So I'm, maybe overly hopeful, thinking that that's contributed to the solution, but I'm still concerned that we haven't addressed enough the larger issue of calorie-dense junk food, which is everywhere in our environment, and is a big contributor too. Yes.
I'm interested in sort of the ultimate goal of all of this, and in part it has to do with the question is, what is it okay for people to die from? And the reason why I ask that question is we see this in many public health things, that you have a list of people die from heart disease, cancer, diabetes, and I assume that means that it's like not right that people should die from that.
Right.
So I'm wondering what it would be right for people to die from, and that this sort of relates to the question of your use of the term saving lives, which seems to me to be very grandiose, since everybody will die at some point, that we don't really save much in the way of lives. But when public health accomplishes what it should accomplish, what will that chart look like of what people die from?
Yeah, good point. It may very well be that it'll still look the same, that it will be chronic diseases that are the #1 killers. And if I showed that graph and our life expectancy were at the top of all the countries in the world, then I might say, well, actually, we've maxed out. We can't get any healthier. We all should go home and do something else. But that's clearly not the case. Clearly, we could be a lot healthier, and those chronic diseases might kill us a lot later if we did a better job than we do right now. And you know, for simplicity's sake, I talk about deaths prevented. You could have a more sophisticated analysis that looked at years of life lost or disability-adjusted years of life lost. And I've done that, and the conclusion you come up with around our risk factors and what we ought to focus on is pretty much the same. Yes, I got a question here. Here comes a mic.
Thank you. Thank you, Tom. That was terrific. And I also agree with Sandra. Your book is terrific. It's a great read. And that's from someone who even knew how it was going to come out at the end. But one of the things you say at the end that both startled and pleased me was that old-time public health relied on epidemiologists, microbiologists, inspectors, and you think that modern public health, at least dealing with the issues, the chronic disease issues you pointed out, is going to rely more on economists, lawyers, policymakers, activists, and media experts, as you said already before. Can you elaborate? I agree with you, but can you elaborate on that a little more?
Yes, I mean, and that's the list that you just gave is the list of expertise that we need to engage in this world. So lawyers, economists, people with expertise in mass media. I forget what else put on the list there. Policymakers, people who, you know, in community organizing and advocacy. It doesn't mean that we don't still need to have sort of the hard sciences as well, but we do need to have those sorts of folks there. And you know, as health departments, we need to try to figure out how to bring those people in. As schools of public health, we need to think about how to train people so everyone has a basic knowledge of it, and then some people are truly experts in that. And that is, it's a very different world, and we need to, you know, really change for it. Got a question there.
I guess my question is, so it seems to me that the food industry has become savvy, and they've now started labeling things that are equally terrible with things like healthy, or, you know, that's been the shift now in the food industry. Do you know anything that's being done to kind of change that narrative on the public health side?
Well, I can just say one concrete thing. I know that FDA released a docket yesterday or the day before to define the word natural, because I've seen that there's no more powerful word right now in food marketing than natural. And you know, many things that are natural are in fact extremely unhealthy, but people, if they see it's natural, well, then it must be healthy. They're so confused that they figure, well, the default is if it really came out of nature, it's probably healthy, so it's not an illogical approach. So defining natural may help, so that people, they can't slap it on really bad stuff. But I would say no in general. I think the food industry has succeeded in confusing and diverting people with these other labels. And I said, you know what, a organic, GMO-free, you know, gluten-free brownie is still junk food, right? And if you go into Whole Food, you get an awful lot of that. And so I don't think in public health we've been able to really engage in that conversation, but probably should. I got a question here. Oh, and then one up there in the back afterwards.
Hi, thank you so much. So I've been thinking a lot about poverty and race in particular. And it just seems to me that we're no further along than we have been over the past 20, 30, 50, 60 years and really getting to the root of the disparities that we see. And when I think about, you know, if you showed a different chart and you showed life expectancy of men over the years, Black men are actually, their life expectancy is what the life expectancy was back in the 50s for white men. And I just, we're sort of stuck in public health in this sort of incrementalism that seems to trap us and really be able to get to like these root causes. And it just seems like we keep having the same sort of similar dialogues year after year, and we still have the same issues. And I'm wondering if you can comment on that and sort of how, just even thinking about some of the simple policies like flavor bans, right, and what the FDA has done. Yet menthol is exempted, and we know that communities of color use menthol tobacco products at higher rates than white populations. So I'm just wondering if you can just comment a little bit and maybe try to help us push this conversation into a direction where we really, really need to go, like ASAP.
Yeah. I would say around the health equity issue in general, with every policy we ought to be thinking, how does this policy help reduce health equity as in addition to helping the general population? Now, it turns out that most of those behaviors on that list there are more common among people of low incomes for a variety of reasons. And so most of the things that we're going to do that will help the entire population will disproportionately help the poor and racial minorities. That's a good thing. But at the same time, we ought to be addressing these structural social determinants, and we ought to be clear about that. Now, but I will confess that I am not the best expert in trying to figure out, okay, we know we've got racial injustice in this country still. We know that if you're African American, you can have many fewer opportunities your entire life than if you're white. How do we solve that problem? I don't know how to solve that problem either, but I think we need to be at least discussing how we try to solve that problem. I do think we've sometimes made a mistake in this country in public health people saying, okay, well, what we're going to do is we're going to fund this community group in a low-income neighborhood, and they'll figure out how to solve the problem. They are the most powerless amongst us, right? So they are the ones least equipped to be able to actually solve this problem. The power is among rich white people like me. And so we have to figure out how to change the power structures, and I'm not the best to figure out exactly what that means.
I don't know if you noticed it on your way in, but we have a Boston Medical Center is a smoke-free campus, and it's surrounded with cigarette butts on our sidewalk. And going off of that, I just feel my intuition in some of this is just that this still feels really top-down to me. You mentioned power in your last comment, and I think the one thing that we don't have is a really true knowledge of what's effective in the community, and we as public health researchers really like community-based research. And I'm wondering if we could adopt something like community-based advertising, because I still feel that the people sitting around the table creating these advertisements or putting up the sign on the sidewalk that says BMC is a smoke-free campus, and the evidence is all around it, that we're just not, I don't know that we're really getting there, because I don't know that we're really getting the community perspective on the development of these messages.
Well, I definitely think that you need to get the perspective of people who are you're trying to reach in developing any sort of messages. That doesn't mean, though, that you leave it up to them to try to run an entire campaign. When I think about how to use marketing, I almost always go back to the way that Coca-Cola works. They wrote the book on marketing. They're brilliant creative marketers. They do a lot of things that I don't like at all, but their methods are worth learning from. And when they want to change behavior, what do? They certainly, I'm sure they do an awful lot of focus groups and an awful lot of surveys, but at the end, they create these very powerful, emotional messages out there, and they blast us with it. We see it everywhere we turn, and with that, they're able to boost consumption. And so we need to borrow some of those techniques where we learn from the people we're trying to reach, but in the end, we're using the power structures of our society to make the change we want to have happen. I see a question here.
Thank you, Dr. Farley, for this wonderful presentation. It's something that I think about all the time. I really enjoyed how you incorporated the Brita advertisement, and that made me think about the fact that we use a lot of public funds to promote this type of research and to create our own advertisements. So I was wondering if you could talk a little bit about maybe partnering with companies like Brita. I know that it's kind of like working with evil corporations that we're trying to fight against at the same time. But I think that they have the resources that we need to make a difference and to make a change, in the media narrative.
Yeah. So this is very real for me in my current position where we're trying to be doing media campaigns and we're looking for funding. And so we're trying to figure out what, do we work with no corporations whatsoever? Do we work selectively with corporations? Under what rules we work with them? And I do think that there are some corporations that we should never work with because the perception of conflict of interest is so great. Even if there was no involvement in the content, we would just ruin our reputation. So we are not going to accept money from the soda industry. We're obviously not going to accept money from the tobacco industry. But could Brita fund a education campaign around sugary drinks? I would certainly be willing to talk to them about it, absolutely. And we ought to be looking for those partners where the interests are aligned. We also need to have a process by which we make sure they don't have undue influence on what comes out.
I think given the time, we're going to stop here. But we have a reception. Dr. Farley will be around if people want to ask him one-on-one. But I thought this talk was absolutely fabulous, and it's truly resonant, I think, with a lot of discussion we've been having as a school, where we have been really trying to grapple with what is the role of a school of public health, and where we have said we generate knowledge, we teach that to our students, and we take a part in translating that knowledge towards the end of making the world a better place. And I think what Dr. Farley is doing is just that. And the question for us, I think, as a school community is how we intersect with people like Dr. Farley who are doing this work so that we actually bring about that synergy that you showed in your slide about various media spaces, and I would argue knowledge generation spaces towards this common end. That was really inspiring. Thank you very much.